Yes. Okay. This patient has intermittent episodes of apnea defined as periods of more than 20 seconds without respiratory effort. In a preterm infant with normal physical examination, in a preterm infant with a normal physical examination who appears well between episodes, the most likely cause of apnea of prematurity is a type of central apnea, no respiratory fault, caused by immature central respiratory centers in the brainstem. These respiratory centers are responsible for in normal respiratory drive. In apnea of prematurity, the signal to breathe intermittently fails to generate. Apnea of prematurity may not be evident immediately after birth, but typically presents in first few days of life with episodic respiratory pauses, often with associated bradycardia and desaturation that may initially increase in frequency. Diagnosis is generally clinical, however, chest X-ray is often performed to exclude pulmonary pathology during the evaluation for alternate causes. Apnea of prematurity does not cause abnormalities on X-ray, but concomitant lung disease caused by prematurity may be seen, as in this patient with bilateral granular opacity from resolving respiratory distress syndrome. Mild apneic episode may not require treatment. However, spells that are prolonged, frequent, or associated with bradycardia or hypoxia, as seen in this patient, can cause repeated partnership insults to the brain white matter, which can result in CP, cerebral palsy. Therefore, treatment with caffeine therapy and non-invasive respiratory support, high flow nasal cannula, continuous positive airway pressure is warranted. Caffeine is methylxanthine that chemically stimulates the respiratory drive and is given until the and is given and is given until the respiratory centers mature, which typically occurs by the expected date. Okay, next. Okay, it is HST, hereditary hemorrhagic telangiectasia, because in the stem they have told that he also reports frequent episodes of epistaxis since childhood, but has no other medical condition. So looks like it's hereditary hemorrhagic telangiectasia, recurrent epistaxis. Okay. This patient's constellation of hemoptysis, chronic recurrent epistaxis. This patient constellation of hemoptysis, chronic recurrent epistaxis, pulmonary bruit, and nodular lung lesion, and anemia is consistent with hereditary hemorrhagic telangiectasia. HHT is caused by autosomal dominant mutation of the genes involved in angiogenesis, leading to mucocutaneous telangiectasia and visceral organ AV malformation in the upper respiratory tract. Nasal telangiectasia account for recurrent epistaxis, often beginning in childhood. Pulmonary AVM consists of anastomosis between the branches of the pulmonary artery and comparison pulmonary veins. They usually become symptomatic in early adulthood, presenting with hemoptysis. They appear as multifocal, well circumscribed, small nodules on chest X-ray. Because AVM blood flow is turbulent, a continuous pulmonary bruit may be auscultated over the area. Infracapsular murmur in this patient. Gastrointestinal angiodysplasia affects all portion of the digestive tract, predominantly the stomach and small bowel, leading to acute and chronic blood loss, resulting in IDA. Require Patients frequently require an iron repletion and or red blood cell transfusion. In patients with symptomatic bleeding AVM hemoptysis, management involves pulmonary angiography followed by embolization. Some of these patient epistaxis hemoptysis pulmonary nodules overlap with granulomatosis with polyangiitis, a necrotizing small vessel vasculitis, that can affect the respiratory tract, classically presenting as pulmonary renal syndrome. However, involvement upper airway involvement include nasal septal necrosis and destructive sinusitis. Lower airway involvement includes diffuse alveolar hemorrhage, crackles, diffuse patchy infiltrate and renal involvement manifests with microscopic hematuria on urine analysis, not seen in this patient due to crescentic glomerulonephritis. Because GPA affects microscopic hematuria on urine analysis, not seen in this patient due to crescentic glomerulonephritis. Because GPA affects capillaries and small blood vessel, macroscopic radiographically detectable AVM with accompanied bruit are unlikely. Okay. Yes. Is normal or increased? Yes. It is AS, and it is restrictive lung disease. No, no, no. It's restrictive lung disease. Chronic low back pain. Chronic low back pain in an otherwise young, healthy man. Pain at night. Improvement of pain with activity and evidence of an elevated ESR rate are suggestive of yes, chronic inflammatory disease, axial skeleton characterized by progressive stiffness of the spine, sacroiliitis on radiography, and positive serology on HLA-B27. In the majority of the patients, some patients can develop. Some patients also develop extraarticular feature such as anterior uveitis, inflammatory bowel disease, cardiac involvement with AR. Patient with AS can develop limitations in the lung expansion due to diminished chest wall and spinal mobility. Pulmonary function test may reveal mildly restricted pattern with reduced vital capacity, mildly with reduced vital capacity and total lung capacity, but normal FEV1 by FVC ratio. Functional residual capacity and residual volume are normal or increased due to increased fixation of rib cage, increased fixation of rib cage as in inspiratory position. Okay. Okay, rib fracture with hemothorax. Okay, this patient with isolated blunt chest trauma. This patient with isolated blunt chest trauma, blow to the chest on the table, blow to the chest on the table, now as symptomatic hypotension, lightheadedness, tachycardia, flat jugular veins, concerning for hypovolemic shock because because each half of the chest can hold up to 40% of the circulating blood volume. Large intrathoracic hemorrhage, hemothorax can lead to acute hemodynamic instability. Hemothorax, diminished breath sound, dullness on percussion may result from injuries to large aorta, hilar vessels, or small intrathoracic structures, intercostal blood vessel, lung parenchyma, given these patients pleuritic chest pain and exquisite chest wall tenderness, exquisite chest wall tenderness to palpation, the most likely source is fractured ribs and intercostal vessel injury. Hemothorax is treated with deep thoracostomy, which is sufficient to resolve in many cases, although if immediate chest tube output more than 1500 ml of blood, emergency surgical thoracotomy is indicated. Okay, can you give me 5 minutes? I'm coming. Okay. Hello. Yes, I can hear you. Okay. Okay, it's not aspiration pneumonia, it's not myocardial contusion. This too is confirmed. Chest X-ray show uh, ground glass opacity. Chest CT, sorry. CTs can show a ground glass opacity in the both lung. So- Yes. No, I don't think so. It does not. Hemothorax with and he has already got plenty of received 3 liter of fluid. That's why blood pressure is controlled. And hemothorax mere it does not cause ground glass opacity. Yes, probably. Okay, I don't not know how to diagnose pulmonary contusion. Is any blunt chest trauma can cause pulmonary contusion? Thoracic aortic injury, like bronchial rupture. Yes. Okay, I'm reading the box first. Uh, Present less than 24 hours after blunt thoracic trauma. There is tachycardia, tachypnea, and hypoxia. Tachycardia, tachypnea, and hypoxia. Diagnosis: RALS or decreased breath sound. RALS or decreased breath sound. Chest, CT chest, CT scan or chest X-ray with patchy alveolar infiltrate not restricted by anatomic borders. CT scan or chest X-ray with patchy alveolar infiltrate not restricted by anatomic border. Management is pain control, pulmonary hygiene, incentive spirometry, chest physiotherapy, supplemental oxygen, and ventilatory support. Despite being restrained during the high-speed motor vehicle collision, the patient sustained blunt thoracic trauma wall with chest wall bruising, likely from airbag impact. Blunt force to the chest wall can the underlying lung, injure the underlying lung, resulting in alveolar hemorrhage and edema. Subsequent resuscitative fluid administration can exacerbate the alveolar edema, leading to progressive dyspnea, tachypnea, and hypoxemia. On CT scan, the alveolar edema can appear as ground glass opacity in the lung adjacent to affected chest wall anterior peripheral lung. In this patient, this pattern and distribution are classic for pulmonary contusion. Pulmonary contusion is common 25 to 35% cases following blunt thoracic trauma. Because clinically significant alveolar edema may take up to 24 hours to accumulate, pulmonary contusion may not be apparent immediately after injury, and initial chest X-ray is often negative. CT scan of the chest is more sensitive. Look at the CT scan and can reveal irregular non-lobular infiltrate. Irregular non-lobular infiltrate not restricted by anatomic border landmarks infiltrate. Management of pulmonary contusion involves pain control, pulmonary hygiene, and respiratory support. Yes. Tachypnea and hypoxemia in the setting of femur fracture are concerning for fat embolism syndrome. However, fat embolism syndrome typically occurs more than 24 hours after the injury and neurological dysfunction, and usually present more than 50% of cases, a petechial rash occurs in some cases, less than 50%. Okay. There is a sudden drop in the blood pressure, isn't it? Blood pressure was 160. Slow. Oh, there is bradypnea. Respiration was previously low and it is again more low. Anesthesia terminated after successful. Yes. Patient is breathing. Laryngeal edema. Postus. Is it patient is ongoing hemorrhage? That's why BP is low. But why there is a respiratory acidosis? Respiratory acidosis. Okay. Delay. Okay. Return to consciousness after anesthesia. Imagine. Return to consciousness after anesthesia. emergence typically occurs within 15 minutes of extubation at a minimum patient should be responsive intact intact protective reflex within 30 to 60 minutes of the administration 30 to 60 minutes of last administration of anesthetic or adjuvant agent, opioid, muscle relaxant. Delayed emergence occurs when a patient fails to regain consciousness within the expected window. The etiology is typically multifactorial but generally occurs due to 1 to 3 major causes: drug effect, metabolic disorder, and neurologic disorder. Drug effect is preoperative drug ingestion like opioid, benzodiazepine, illicit drugs, anticholinergic drugs like antihistamine may potentiate anesthetic effects. Doses. Prolonged anesthesia duration or higher medication doses may also delay emergence. Metabolic disorder common etiology include hyper or hypoglycemia, hyper or hypothermia, hyponatremia, and liver disease. And neurologic disorder, intraoperative stroke, seizures, or elevation of intracranial pressure can cause prolonged alteration in mental status. These patient arterial blood gas demonstrate an acute hypercarbic and hypoxic respiratory failure, low pH, elevated PCO2, low PO2 due to hypoventilation. In addition, in association with worsening bradypnea and drop in pulse, which were likely initially elevated due to agitation post-extubation, this suggests that the patient's delayed emergence is due to medication effect, prolonged medication effect, possibly potentiated by preoperative drug or alcohol ingestion. In this patient with a history of polysubstance abuse, management of acute respiratory failure include ventilatory support, bag and mask reintubation. Reversible agent naloxone may be indicated. Okay. Yes. Current condition is, I think that he has pneumonia, so it is antibiotics, so it is resolved. But now again he has problem, isn't it? Is it para? Sorry. Yes, because now he has pleural effusion, dullness to percussion, diminished breath sound on the right lung base. So it is parapneumonic effusion. Looks like. So we need to do the X-ray to look at the effusion and do accordingly. Okay. Most children with uncomplicated most children with uncomplicated community acquired pneumonia, most children with uncomplicated community acquired pneumonia typically improve within 48 to 72 hours of antibiotic therapy. This patient with right lower lobe pneumonia, persistent fever despite 48 hours of antibiotics require further evaluation to assess for a complication such as parapneumonic effusion, abscess, necrotizing pneumonia. Therefore, the best next step in the management is repeat chest X-ray to evaluate for pneumonia-related complications. This patient with dullness to percussion, decreased breath sound on examination, likely has parapneumonic effusion in which infection or infection-related inflammation spreads to the pleural space. Parapneumonic effusion can present with symptoms directly resulting from effusion, cough, pleuritic chest pain, dyspnea, or with signs or and symptoms of pneumonia unresponsive to treatment as seen in this patient. Chest X-ray and or ultrasound is performed to evaluate the effusion size and other characteristics. Free flowing versus loculated drainage is indicated for moderate or large effusion, or if the patient is experiencing respiratory distress. This differs from the adult lung population, in which the need for drainage is determined mostly by fluid analysis. Okay, okay. This patient has numerous risk factors for post-operative pneumonia. His age, poor health, scheduled long invasive surgery put him at increased risk. Post-operative measures used to decrease the risk of pneumonia are aimed at encouraging lung expansion. These include incentive spirometry, deep breathing exercise, continuous positive air pressure, and intermittent positive pressure breathing. Of these, incentive spirometry has been shown to be the most effective and is thus the first line preventive measure. Sorry? Okay. Continuous positive air pressure like incentive spirometry promotes lung expansion postoperatively. However, it is more costly and has higher rate of complication than incentive spirometry. For these reasons, CPAP is used only if patients who develop pulmonary complication in spite of incentive spirometry. Okay, okay. This patient with ARDS, this patient with respiratory distress. Okay, first look at the box. Intubation, initial ventilatory support settings, oxygenation FiO to 100%, PEEP 5, VT, ventilation 6 ml per kg, and respiratory rate 14 to 18. Adjust oxygenation and adjust ventilation. Adjust oxygenation if PaO2 is more than 90, hyperoxia, then FiO2 would be decreased. If PaO2 is less than 60, then PEEP should be increased. And adjust ventilation if PaCO2 is higher and pH is less than 7.25, increase respiratory rate and increase tidal volume as a last resort. If PaCO2 is low and pH is more than 7.45, decreased tidal volume, decreased respiratory rate, decreased tidal volume, decreased respiratory rate, and increased sedation as last resort. And increased sedation as last resort. Okay, okay, okay. This patient with respiratory distress, hypoxemia, PaO2 less than 70 milli. Sorry, this patient with respiratory distress, hypoxemia, PaO2 is less than 60 millimeter of PaO2 less than 60 millimeter of mercury and bilateral opacity, likely has acute respiratory distress syndrome, ARDS due to sepsis of urinary origin. ARDS can develop due to direct aspiration pneumonia or indirect trauma sepsis, uh, pancreatitis, trauma sepsis, pancreatitis, lung injury. In ARDS, hypoxemia is mainly due to an intrapulmonary shunt effect caused by neutrophilic lung inflammation and flooding of fibrinous proteinaceous fluid into the alveoli, proteinaceous fluid into the alveoli. Positive end expiratory pressure PEEP often causes positive end expiratory pressure PEEP improves oxygenation by recruiting flooded alveoli and propping them open through the respiratory cycle. Elevated PEEP, more than 10 centimeter of water are frequently required in ARDS. Increasing PEEP in may be carefully done because it can risk the barotrauma, and however increasing PEEP has several beneficial effects. Additional alveoli are recruited and making more of the lung available for gas exchange, reduce shunting. As more alveolar units are recruited, lung compliance may improve because the presence of delivered by the ventilator and is distributed throughout a larger lung volume. If the lung is under-recruited, increased PREP may improve compliance. And mean airway pressure is increased, providing a larger pressure gradient for oxygen transfer across the alveolar capillary membrane. Okay, oxygenation can be improved by FiO2. Patients are often provided more than 60% 0.6 FiO2 immediately after intubation. However, FiO2 is usually weaned less than 60% as quickly as possible to avoid potential oxygen toxicity. This patient may have been providing 100% FiO2, subsequently quickly decreased to 70% FiO2. Increasing PEEP addresses the underlying pathophysiology of the ARDS. In patients requiring improved oxygenation, PEEP should be increased as tolerated to allow for reduction in FiO2. Okay, tidal volume. Can you tell me again what you have said? Okay, On that question, like that was the approach to hypoxemia. Yes, there is another question. Ye- Yes, ARDS, yes. Is it pulmonary embolism? Smoking is one of the risk factor. I sudden severe shortness breath, and there is hypotension, tachycardia, tachypnea, JVP is elevated. Hackor, and he has hypertension. Smoking history, medical history, diabetes for 10 years, hypertension for 6 years. Looks like, I do not know. I don't know. It fits. Sorry. Yes, it fits. And another thing, like look at the irregular pulse, atrial fibrillation, irregular pulse, irregular. Atrial fibrillation can cause irregular pulse. AFib can cause P. Maybe there may be association with P. Maybe. Don't jump into my answer because these days I made lots of mistakes. Obesity has association with P. How? Don't look for risk factor. Just think about the symptoms. Symptoms, symptom, symptoms fit. No, no, no. Maybe P, because symptoms fits. Because the our symptoms actually fits, like hypotension, tachycardia, tachypnea, and some ECG problem. Okay. Okay. The manifestation of pulmonary embolism are non-specific and variable. Acute onset dyspnea, chest, pleuritic chest pain, acute onset dyspnea, pleuritic chest pain are the most common cause of these symptoms. Acute onset dyspnea, pleuritic chest pain are the most common cause of these symptoms. Occurring in 73 and 66% of the patient respectively. Hemoptysis occur less than 20% and symptoms of a DVT less than 30%. This patient has multiple physical examination finding consistent with PE, including tachypnea, tachycardia, hypoxemia, low-grade fever, and JVD distension. She does not have classic findings of pulmonary embolism on ECG. Prominent is in lead 1, Q in lead 3, and inverted T in lead 3 S1 Q3 T3 on chest X-ray Hampton Westermark sign, but such patients are present in only a minority of the cases. Atrial fibrillation recognized by irregular RR interval with a narrow QRS complex. An absence of organized P wave is commonly associated with P may result in PE-induced atrial dilatation, increased sympathetic tone. In some cases, the atrial fibrillation may be the atrial. In some cases, the atrial fibrillation may be the cause rather than the result of PE due to embolization. due to embolization. Oh,